Welcome back to the PEM Fellowship EKG curriculum. Our topic for today is ischemia and infarct. This module should run for about 11 minutes. Remember that you can always refer back to the basics module if you have any questions, and that you should pause this module if you need more time to review the EKGs shown. First, let's start with a case. You are seeing a 14-year-old male who presents with chest pain for 2 days. The pain is positional and seems to be worse when he is lying down. He denies shortness of breath, lightheadedness, dizziness, or fever. His vital signs show a heart rate of 94, a blood pressure of 106/60, and an oxygen saturation of 99% en room air. His chest x-ray is benign. You decide to get an EKG. And this is what you see. Let's use the method we learned in our basics module to go through this EKG together. Calculate the rate, rhythm, and axis. You should have found that the rate is just over 100, which is a little fast for a 14-year-old. You can see a P for every QRS and a QRS for every P, so this is sinus rhythm. The QRS complexes are up in 1 in AVF, so this EKG has a normal axis. Use this enlarged version of the EKG to calculate the PR and QTC intervals. You should have found that the PR is about 150 and the QTC is 401 if you use 7.5 small boxes for your QT and 14 small boxes for your RR. Now take a minute to look at the morphology. You should have found that most leads have at least mild ST elevation. This diffuse ST elevation is consistent with pericarditis. Other findings you might see in pericarditis are diffuse PR depression and T-wave inversion. These findings are not seen on this EKG. Pericarditis can result from a number of causes. It is often infectious, but may also be post-surgical, post-traumatic, or occur after exposure to certain drugs or toxins. It may be due to metabolic disorders like thyroid disease or uremia. It is also seen in patients with malignancies and collagen vascular disease. The remainder of cases are considered idiopathic. The majority of cases of pericarditis are treated with NSAIDs such as ketorolac and activity restriction. If this is unsuccessful, steroids may be necessary. Now that we've talked about pericarditis, let's try another case. You are seeing a 7-year-old male who complains of pleuritic chest pain for 1 day. The pain is positional and seems to be worse when he is lying down. He denies shortness of breath, radiation of the pain, or fever. His physical exam is remarkable only for tachycardia. His vital signs show a heart rate of 135, blood pressure of 90/40, and an oxygen saturation of 99% en room air. You decide to get an EKG. And this is what you see. Let's use the method we learned in our basics module to go through this EKG together. Calculate the rate, rhythm, and axis. You should have found that the rate is just under 150, probably closer to 130, which is a little fast for a 7-year-old. You can see a P before every QRS and a QRS for every P, so this is sinus rhythm. The QRS complexes are up in 1 in AVF, so this EKG has a normal axis. Use this enlarged version of the EKG to calculate your PR and QTC intervals. In this EKG, the PR is about 110 and the QTC is about 422 if you use 7 small boxes for your QT and 11 small boxes for your RR. Now take a minute to look at the morphology. You should have found that this EKG has normal morphology, with the exception of low voltages throughout. One other subtle finding on this EKG is electrical alternans in V1. With these findings, you decide to go back to listen to your patient again. This time, you hear a friction rub on exam. Given that your patient has a friction rub, low voltages, sinus tachycardia, and electrical alternans on EKG, we worry about a pericardial effusion. Electrical alternans is a beat-to-beat variation in the QRS axis that is due to the swinging of the heart within a large pericardial effusion. Remember that you can see electrical alternans in other tachycardias, so it is a nonspecific finding. If your patient is showing symptoms of a pericardial effusion and is hypotensive or is showing signs of poor perfusion, be sure to think about cardiac tamponade. With treatment, the EKG findings of pericardial effusions often resolve within 1 week. Shown here is the EKG of your same 7-year-old patient 1 week after drainage of his large pericardial effusion. He is less tachycardic and his low voltages have resolved. Now let's change gears and try another case. This time you have a 6-year-old female who presents with complaints of fevers, myalgias, and feeling weak for 2 days. She denies shortness of breath, lightheadedness, dizziness, and chest pain. On exam, the patient is afebrile. She is tachycardic and you do not appreciate a murmur. Her vital signs show a heart rate of 150, blood pressure of 100/60, and an oxygen saturation of 98% on room air. Given her tachycardia, you decide to get an EKG. And this is what you see. Go through this EKG on your own and identify any abnormalities. You should have found that the only abnormality on this EKG is sinus tachycardia. This patient actually has myocarditis, but it is important to recognize that EKG findings in myocarditis are unreliable. The most common finding is sinus tachycardia, but you may also see PACs or PVCs. We worry about patients with myocarditis because they can quickly develop ventricular arrhythmias. When thinking about myocarditis, it is important to remember that the EKG is unreliable. Diagnosis is made with clinical suspicion, elevated cardiac enzymes, cardiac biopsy, and transthoracic echo. In general, treatment is supportive. Okay, now we have covered pericarditis, pericardial effusion, and myocarditis. Let's try one last case. You are busy seeing patients in the ER when your charge nurse tells you that a hospital employee has just registered to be seen because he is having chest pain. He explains that he is having substernal chest pain that started about 30 minutes ago. It is radiating to his neck and jaw. He does have dyspnea and tingling in the left arm, and he tells you that this feels exactly like when he had his last heart attack 1 year ago. His vital signs show a heart rate of 100, a blood pressure of 125/70, and an oxygen saturation of 98% on room air. The rest of his physical exam is normal. You decide to get an EKG. And this is what you see. One last time, let's go through this EKG together. Calculate the rate, rhythm, and axis. You should have found that the rate is just over 100, probably closer to 110. You can see a P for every QRS and a QRS for every P, so this is sinus rhythm. The QRS complexes are up in 1 and AVF, so this EKG has a normal axis. Use this enlarged version of the EKG to calculate the PR and QTC intervals. In this EKG, the PR is about 110 and the QTC is 416 if you use 7.5 small boxes for your QT and 13 small boxes for your RR. Now take a minute to look at the morphology. You should have found that while the P and T waves look normal, there is significant ST elevation in leads V2 and V3, as well as some in V4 and V5. These ST elevations are concerning for an ST elevation MI, or STEMI. In an ST elevation MI, you may see ST elevations, T-wave inversions, and Q waves. These changes and the specific leads they are found in may help localize the ischemic damage to a certain coronary vessel or a particular part of the heart. Q waves typically indicate myocardial necrosis. ST depressions often represent ischemia without true infarct. Remember that patients may also be having an MI with no EKG changes at all. This is referred to as a non-ST elevation MI, or NSTEMI. In terms of localization, the precordial leads represent an anterior or left ventricular MI. Specifically, V1 and V2 indicate anterior septal infarct, V3 and V4 represent anterior apical infarct, and V5 and V6 represent anterior lateral infarct. Leads 1 and AVL represent a lateral infarct. Leads 2, 3, and AVF represent a right ventricular or inferior infarct. In general, patients with symptoms concerning for MI should be treated similarly. They should be placed on oxygen and given 325 milligrams of aspirin that they should chew instead of swallow to increase absorption. You can use sublingual nitroglycerin every 5 minutes until chest pain resolves, as long as the patient's blood pressure tolerates it. You can also use morphine if the patient's chest pain is not improved with nitro, or if their blood pressure drops to the point that they cannot tolerate anymore. At this point, the goal is to transfer the patient to a facility where further evaluation and management can be accomplished. If transfer is going to be delayed, consider beta blocker therapy and a heparin drip. There are 2 other key points to remember when treating suspected MIs. If the patient has a right ventricular or inferior wall MI, as shown here in this EKG, the heart becomes preload dependent because the RV has decreased systolic function. Therefore, if you give medications to lower the preload, like nitroglycerin, you will cause a drop in blood pressure that the patient will not tolerate. In anybody with an inferior wall or right ventricular MI, do not give nitroglycerin. Instead, give IV fluid boluses to maintain preload and use morphine to control pain. You should still give aspirin and place the patient on oxygen like you would in any other patient with myocardial infarction. In inferior MIs, you should also watch out for sinus bradycardia or heart block, because the right coronary artery serves the SA and AV nodes. The other type of MI that you treat differently is one that is induced by cocaine. Because MIs due to cocaine are due to coronary artery vasospasm, use benzodiazepines to relieve the spasm and avoid beta blockers, as they may worsen the vasospasm. We have now gone through various examples of ischemia and infarct. Some key points to remember are that pericarditis on an EKG presents with diffuse ST elevations, PR depressions, and T-wave inversions, although you may not see all of these findings at the same time. Pericardial effusions on EKG are characterized by low voltages and electrical alternans. In myocarditis, EKGs are unreliable. In MIs, you may see ST elevations or depressions, T-wave inversions, and Q waves depending on the location and timing of the infarct. We hope that you are now more comfortable recognizing the findings consistent with ischemia and infarct and are familiar with the basics of the management of these various conditions. As always, we welcome your feedback and suggestions. Thank you for completing this module.